Hey guys, I wanted to go ahead and record these lectures for that we were going to do on Monday, and I'm going to put them in the course for you. I have been working on these as well as storm prepping, so I do know a little bit of what you all have been going through, as I have had to prepare as well and try to get these things for you all, because again, I want you all to, me and Dr. Daniels both want you all to succeed. And even though this hurricane is coming through and it may leave us without power, you'll have these lectures to listen to so that you can study while we are out. Definitely read your books and do whatever you can while we are out of school. So what I've got here is Threats to Oxygenation, Part 3. It's the 3A lecture, which talks about vascular lung disorders and core pulmonale. It's a real short lecture, so it's only 18 slides. I'm going to go through it pretty quick, and you can actually pause it if you need to and go back when you re-listen to it. This right here is, some of it is review for you, but I felt like it was important because it does play a big part into heart failure, which is also a review for you. But again, it's important information to know about the heart and about what we're studying. So if you want to read along or if you want to review the pages, it's pages 553 through 556. Which is only roughly 3, 4, 5 pages, but it is, like I said, important information. So, pulmonary embolism. What is it? It's a blockage of pulmonary arteries by thrombus, fat, air embolus, or a tumor. It blocks alveolar perfusion. So I showed you all a video the other day about pulmonary embolism, how DVT can turn into a pulmonary embolism, and so it's it's anything really that blocks the arteries. 30% of patients die from recurrent embolism. So that is significant. And a lot of times, because the higher blood flow, because when there's a blockage, there's a higher flow. So think of that. The lower lobe of the lungs are commonly affected. Next is just a picture. I thought this was significant because a lot of people like pictures. These are actually some pulmonary emboli in the lungs. And then on the right there, it's a actual pulmonary embolus. So what are the risk factors? Deep vein thrombosis, or DVT, like the video that I showed you all the other day. Immobility, of course, if you're not moving. Surgery. Oral contraceptives. Obesity, malignancy, smoking, heart failure, AFib, central lines, or central line devices, and fracture of long bones. Those are all your risk factors for pulmonary embolus. What does it look like? When you're assessing your patient or when you're looking at your patient, what are you going to see? You're going to see dyspnea, tachypnea, cough, of course chest pain, hemoptysis, crackles in the lungs, wheezing. Sometimes you'll have a sudden change in mental status. because why do you think that is? Well, sudden change in mental status is usually due to the lack of oxygen, right? Syncope, tachycardia, and like I said, hemoptysis, I already said that. But the mortality rate for a massive PE is 30 to 60%, with most deaths occurring within 1 to 2 hours of onset. So, and then sometimes small emboli can even go undetected, and they can produce transient symptoms, vague. So just keep that in mind as well. What are the complications? Of course, pulmonary infarction, and we've already learned about infarction, right? So infarction is death of the lung tissue. If it's not getting the oxygen it needs, it can't perfuse. Another complication is occlusion of a pulmonary vessel, which can be the large or the medium pulmonary vessel. And then another complication is right ventricle hypertrophy. And then pulmonary hypertension. We're going to talk more about pulmonary hypertension. Just remember that pulmonary hypertension results in dilation. Dilation means make bigger, right? And hypertrophy of the right ventricle. So these are all complications that can happen from a PE. How do we figure out what's going on with the patient? Patient comes in with chest pain. Often they'll do the whole cardiac workup, but they'll also do these things because chest pain indicate, shortness of breath could be a PE. So they'll do ABGs. A lot of times the PaO2 is low because of inadequate oxygen, secondary to the occluded pulmonary vasculature. Chest x-ray, ECG, of course, they're going to do ECG. Troponin level, just because, they're having chest pain. And a BMP. They'll do a D-dimer, and a D-dimer is just a test that measures the amount of cross-linked fibrin fragments. And these fragments are the result of a clot degradation. And they're rarely found in healthy individuals. So this is a very good test for a PE. Well, you're going to talk more about D-dimer and all when you talk in the next lecture. Not the heart lecture, but you do talk some more about this for test 3. Then another thing that's a useful test is a VQ scan. The VQ scan is a test that, a VQ scan is has 2 components, and it's the first component of it is a perfusion scanning, which involves the IV injection of a radioisotope, which is like a nuclear scan, and it basically a scanning device images in the pulmonary circulation. And then it also involves ventilation scanning, which is involves inhalation of a radioactive gas, and then that scan reflects the distribution of gas through the lungs. So that's the ventilation component These oftentimes are done in the emergency room. So when I used to get a lot of chest pain patients, they would let me know in their report, that all these tests were done. And they'll say, D-dimer is negative, EQ scan is non-significant. So a lot of times these are done pretty quickly, like I said, in the ER. Pulmonary angiography may also be done, and it is the most sensitive and specific test for PE. It is expensive and invasive because you have to, put in a catheter, So angiography, just like we talked before, looking for blood clots in the coronary vessels. Same thing, angiography is they have to insert a catheter through like the antecubital or femoral vein, and they look with contrast media for those clots. So prevention is a key here. And that is why we do all we do. We get people out of bed after surgery. We do the prophylactic measures in the hospital, Lovenox and all that. We put those sequential devices on people. All that stuff is very important. I know it feels sometimes like, very monotonous doing all that, but it is important to prevent these PEs. And then, of course, oxygen is also helpful in caring for them. So let's talk a little bit more about drug therapy. Your anticoagulants are your low molecular weight heparin, which is Lovenox, right? Unfractionated IV heparin. And then also warfarin. You also have to monitor PT, INR with warfarin, and then on your heparin, a lot of times they'll monitor PTT, although it's not necessary when you're using small doses, but they probably will. A lot of doctors will. And then sometimes they'll even use fibrinolytic agents. Same thing, TPA, like we talked about before, because that can dissolve the embolus, right? Surgical therapy. A pulmonary embolectomy. They'll go in. Although hemodynamically unstable patients with massive PE, those are the ones they'll often go in and do a pulmonary embolectomy because it's, more emergent. And it has a high mortality rate, so it's not recommended for patients who can be successfully treated otherwise. And then a lot of times if they think they may be prone to further emboli, or they'll even put in a inferior vena cava filter or an IVC filter. And this is the treatment of choice for patients who are high risk. And, even patients that have a contraindication to anticoagulation. And you can see there's pictures here. These are some different types. I just made little check marks by them. So how are we going to teach about this? Of course, we said prevention is a key, and how we're going to manage it. So in the hospital, you're going to have the patient in semi-filers. Of course, you want them to have IV access, right? A lot of times they'll be on bed rest. and then the Fowlers to facilitate breathing. You're going to have oxygen as ordered. Of course, you're going to frequent assessment. We tell you all frequent assessment. People can change so quickly, and you're going to be assessing lung sounds, vital signs. You're going to be watching these patients because that can be serious. You're going to monitor the patient for bleeding. That's another frequent assessment. Monitor labs. You're going to give them emotional support. They're usually anxious because of the pain. They may have a sense of doom, inability to breathe, even fear of death. And as we've talked about before, when you're anxious and you're not breathing well, then you're having you can have decreased cardiac output. So anytime you can help relieve some anxiety, it's just better for the patient overall. DVT prevention, like I said, you're going to have those prophylactic measures in place. And then definitely the importance of follow-up exams. And then as far as the evaluation goes, how are we going to know if what we've done or what we're doing is working? Well, adequate tissue perfusion, of course. How are you going to tell that? Your ABGs, your mental status, your assessment, and then adequate cardiac output. You're going to be able to tell that by their blood pressure, their heart rate, their ECG. Another way is if they have increased comfort level. How is the patient feeling? That's always a good evaluation. And then long-term anticoagulants, their thoughts about them, their beliefs, their willingness to be compliant. Teaching, a lot of teaching with all that. So just keep that in mind. And we don't want reoccurrence, even though it is highly likely. The goal, is no reoccurrence of PE. And I'm going to tell you a little bit, like I said, I told you earlier, I was going to tell you a little bit more about primary pulmonary hypertension, because it is a vasculature problem. So what exactly is it? It's elevated pulmonary artery pressure, greater than 25 millimeters per mercury at rest, and greater than 30 with activity. It can be primary disease, or it can be due to insult to the pulmonary endothelium. And then secondary, it results from complications of the respiratory, cardiac, autoimmune disorders, things like that. So primary pulmonary hypertension can be a primary disease because of the insult to the pulmonary endothelium, like we talked about earlier in this lecture, or it can be just results from the complications of respiratory, cardiac, or autoimmune disorders. And remember what I said, that pulmonary hypertension eventually results in the dilation and hypertrophy of the right ventricle, right? So let's look at this pathomap. This is something that I thought was significant. So what happens is insult occurs, whether it's hormonal or mechanical or other, and then the pulmonary endothelial injury happens, and then you have sustained pulmonary hypertension, which leads to right ventricle hypertrophy, which leads to cor pulmonale, which leads to right-sided heart failure. So I thought this was a very important pathophysiology map about what we've just talked about. And then we are going to go right into cor pulmonale. So what is cor pulmonale? It is enlargement of the right ventricle, which is caused by a primary disorder of the respiratory system. It can be caused by pulmonary hypertension. It can be caused by COPD. And they may or may not have heart failure, but a lot of times they do. In cor pulmonale, you'll see distended neck veins, shortness of breath, kidney, sodium, fluid retention, swollen ankles sometimes, distended neck veins. So these are things you may see with right heart failure. Enlarged liver or hepatomegaly, swelling of ankles, bounding pulse. Oh, I did swelling of ankles twice. Look at there. I'm just on top of it, aren't I? And then clinical manifestations of lung disease related to cor pulmonale. So you got your COPD patient. A lot of times you're going to see dyspnea, chronic cough, wheezing, crackles, fatigue, chest pain. So how are we going to figure out what's going on with these patients? What tests are we going to run? As far as the diagnostics go, they're going to get a chest x-ray, a BMP, an echocardiogram, and a cardiac cath. And I'm sure more, but those are some of the major ones that they often will do to just see what's going on. And a lot of times, how are they going to treat it? They're going to treat the underlying problem. If it's lung disease, they're going to treat it with bronchodilators, O2 therapy. A lot of times they'll treat it with exercise, and I know that sounds kind of counterproductive, but a good exercise regimen strengthens the body. They're not going to go run on the treadmill for an hour, but anything to add strength and muscle can help a person better utilize their oxygen, their metabolism. And a lot of times these people need small meals, because if you think about when they're metabolizing, when they're digesting, it uses more, even chewing uses more energy. So they're going to need small meals, small frequent meals. And like I said, as far as meds go, anybody with cor pulmonale, you're going to see them on bronchodilators, as you see in the picture, diuretics, blood thinners, calcium channel blockers, surgery is often a treatment. I think that probably should have went over here, right? I'll just share with you all, my mom has COPD, and she did have an episode of AFib, and they put her on calcium channel blocker. So, and a blood thinner. I don't think she's on a diuretic yet. So she really hadn't had a lot of heart failure. So right now, she's just in the lung disease stage. But she does have swelling in her ankles. And they also have given her some bronchodilators. So that is the end of this lecture. Like I said, it's short. It's just an introduction. I wanted to talk about cor pulmonale and how it relates to the lung vasculature. We'll talk a little bit about it in this next heart lecture, but I just wanted to wanted you all to see the actual progression, the actual pathophysiology map of cor pulmonale, because to me it just makes better sense presenting it that way. Again, some of this stuff you may just fly right through and say, oh, this is review, but I felt like it might be helpful. Stay safe, stay dry, and I may see you Tuesday, I may not, but I'll be doing this next lecture on the heart failure. It'll be a review as well, a lot of it, but so you can listen to it or you can not listen to it. But that is the plan. I'm about to do the heart one. So that's the end of this one, and I'm going to stop it and save it.